everybody see my first slide there?
Yes.
Okay. All right. Thanks for the chance to talk about this today. So a lot of work has been done to get the tumor table in place across many sites. And it's happened over many years, but through all the discussions that we've had, we haven't never at all once talked about how to use it. And so that's what we're going to talk about today. And so I think by the time you're done, I think you should be able to create a basic cohort of patients with cancer at a certain site, like lung cancer or colorectal cancer, without too much difficulty. But there's a lot more that you can do beyond that, but it may require a little bit of nuance, not nuisance. So for those situations, I want to tell you about the important things to consider and point you towards some resources that will help you address those things. And so this is going to be a fire hose of information. So this is not so much a how you do it presentation. It's more of a here are the decisions you'll need to make and some resources to help you make those decisions. And so keep in mind that this presentation is mainly about the complications, and I'm a little worried that the one thing I'm going to do here is convince you to never use the data because it's so complicated. Just keep in mind there are resources to help you make the decisions, and it's not as necessarily as hard as I'm going to make it out to be. And then also these slides that I'm showing you here, and then some other reference materials can be found at the link that's right there on the first page. And then we'll also post the recording of this session as well. All right. So before we get into specifics, let me talk about the advantages of the tumor table and when you might want to use it over something like, for example, the CDM diagnosis table. And I think first and foremost, diagnosis date is the big advantage here. It's tempting to look at ICD-10 codes that we find in the diagnosis table, for example, and assume that the date for the first code that you find is the date of diagnosis. And that's not necessarily true. It's not necessarily accurate, especially for academic medical centers. So it's common for people to be diagnosed with cancer someplace else, and they only come to our institutions for specialized treatment or when things get bad. And that can actually be years after diagnosis for some cancers. And so it's important to get this right because a lot of other important concepts are anchored to the date of diagnosis, like survival time and comorbidity and assessing guideline concordance. Like I said, some of this more nuanced stuff that I referred to earlier here. Um, so it's important to get this right. And then also, diagnosis date also allows us to evaluate cancer incidence, which is the number of cases that have been newly diagnosed in a certain time period, as opposed to prevalence, which simply refers to the number of people who are in your group, your population, who had cancer during that time period. They could have been diagnosed someplace else or at some other long ago point in time. Um, that's captured by prevalence. So data diagnosis, very important. Stage of diagnosis. I'm going to have more to say about this in a few minutes. Super important. Determines treatment path for a patient. It determines prognosis. It's also just informative in itself in various different ways, but it's surprisingly difficult to get out of the EHR. We'll talk more. I'll talk much more about that in a moment here. Um, Registry data also includes site-specific variables. So if it's critically important for a particular kind of cancer, it's likely to be included somewhere in the registry data, the tumor table. So breast cancer, for example, this would include things like hormone receptor status. KRAS is a biomarker that's often considered to be important for colorectal cancer, and there's other things called like key 67, I think. It might be key 97. Anyway, another biomarker that's important to have that's also present in our registry data. So let's digging in a little bit more and talk about the structure of the table itself. It's based, as many of us know, it's based on the NACER 2025 specification. It's organized at the tumor level, not the patient level, with one row per tumor. And so it's important to know that each patient can appear multiple times in your registry files if they happen to have more than one primary cancer diagnosed. Multiple records per tumors, as many of you might know, comes up a lot during the QC process as we're looking at our QC reports. So there can be multiple records for the same tumor. This could represent updated records, ascertainment from more than one source. There could be errors and things like that. It's just something to keep in mind as you're interpreting your data. Um, Also important, each tumor corresponds to a unique combination of pad ID and hospital sequence number, which is another variable. Some sites use central sequence number, but more sites use hospital ones, just something to keep in mind. It is also possible that records for the same tumor is found in multiple facilities, but that's true for registries that actually cover more than one facility. Each tumor record is defined as a unique combination of pad ID, sequence number, and facility. And we're actually lucky at Iowa. We have a lot of clinics that are part of UI Healthcare, but they're all under one medical record and covered by a single hospital registry. If there are multiple records for one pad ID sequence number combination, it's almost certainly an error and an easy one to track down. Other registries consider various clinics as different facilities altogether, and the same tumor can have multiple abstracts across those facilities. Um, at the very least, you should know whether your facility variable takes on more than one value, and that will determine how you deal with multiple tumor records. Okay, almost any study that you want to do involves creating a cohort, and that's defining who you're going to study for your project. So what are the inclusion criteria that make somebody eligible, and what criteria excludes people from the study as well? And so one of the main characteristics of any cohort of cancer patients is the tumor site. Where is the tumor located? Is it in the colon, the lung, the breast, and so on and so forth? And the relevant variable for this is primary site that we have there, NACER number 400. This variable is populated with ICD-03 codes. The O stands for oncologies. So ICD-03 codes. There's a link to the ICD-03 manual at the end of my slide deck here. The important thing that I really want to dwell on for a moment here is that these codes, these ICD-03 codes, look a lot like ICD-10 codes, but they are not ICD-10 codes. They're very close, but they're not the same. And so if you look here, we have the ICD-10 codes in one table on the left and ICD-03 codes on the right, and they look very, very similar. And so if you just look at the first three characters, C34 for lung cancer is also C34 for the ICD-03 codes as well. But once again, there's a little bit of nuance here. The ICD-10 codes don't include certain subtypes of lung cancer, the carcinoid tumors, but the ICD-03 codes do include those if you do a query. And then there's some other little tripwires here and there too. The ICD-10 codes for skin melanoma start with C43, but the ICD-03 codes start with C44, and then there's lymphomas and leukemias are also handled much differently as well. Might be some other differences for all I know. The important thing is to make sure when you're dealing with primary site that you're dealing with the ICD-03 codes and not mixing them up with the ICD-10 codes. There's other parts to the ICD-03. I just also wanted to just point out a couple things about the ICD-03 site codes. They're stored without the decimal in the NACER standard. Also, really important point that the registries only record primary tumors. They don't record tumors that have spread to a metastatic site. So if somebody had lung cancer that spread to the liver, that liver is not considered to be another example of cancer altogether. It will not be abstracted in the records. Same thing with recurrent disease. If somebody is treated and their breast cancer goes away, but then it comes back a little bit, in a few years, that's not going to be captured again as a second tumor unless it has certain characteristics. So we're only talking about primary tumors when we talk about what's captured in the registry data. So you have ICD-3 codes that tell you where the cancer exists. You also have a separate type of ICD-10 codes, ICD-03 codes, sorry, that tell you about cancer histology. Histology refers to the microscopic characteristics of the tumor cells. So when you hear about adenocarcinomas or squamous cell carcinomas, neuroendocrine tumors, these are all examples of histological subtypes, and those are captured by another kind of ICD-03 code here. And it's important. This is one of the things that actually is probably one of the harder things for data people to deal with is this particular problem here. It's important to think very carefully about which histology codes to include in your cohort definition. I speak from experience. I once finished an entire manuscript and had to redo the entire thing because pathologists we brought in later on realized we didn't properly consider the histology codes here. And so I'm giving you a few different approaches to how you choose which histology codes to include in your cohort definition. Um, and so like one of the things you can do is simply look at the ICD-03 manual because it organizes codes into basic groups. One of the things I like to do is to use previous literature as a guide. So if you're working with an oncologist or a researcher, um, and trying to develop case criteria for this person, it's often nice to work with them to get a model paper or two or three, some papers that provide some guidance for you on the decisions that you're making, and determine which histology codes they use for theirs. And so that also helps make your projects fit in a little bit more into literature than if you just chosen them de novo by yourself. Another approach that I use a lot is the empirical approach. And so if we're studying, for example, lung cancer, and I'm trying to decide which histology codes to include, I might go ahead and look at C34, which histology codes are associated with C34, and which ones are you see a lot, which ones do you see infrequently, and those will help you make these decisions about which codes to include or not. And so one of the things on the website, the links is actually a list of histology codes with descriptions there. You can download it. You can link it with your own uh, distributions and determine which ones are commonly found, which ones aren't, and then your colleagues can pick it out. The most helpful advice I think that I can give is just take care in making these decisions. Don't make them quick or off the cuff. Give it a little bit of time. And then, so I've talked about two aspects of ICD-03. There's also something else called cancer behavior, which has its own ICD-03 code as well. Generally, you're going to be concerned about malignant cancer. And so usually you select those with that particular variable equal to 3 indicates malignancy. But for other situations, you might be interested in including in situ, for example. And so you can do that if you want. But most of the time, you're selecting for malignant cancers. I might stop here for a moment and just see, are there any questions and am I going too fast or not fast enough before we dig into stage? Have I lost the whole group? I'm going to take silence as okay.
Okay, keep going.
Okay, I'm going to keep going. All right. And so that takes us into stage. You're gonna wish you'd taken a little break at this point because we could spend another hour just talking about stage. And so I'm gonna make it simple. In one case, I have a table here that you can all see that has the most common stage variables that I use. And so this particular table and the variables that are listed here will probably um, help you deal with 80% of the situations that you're going to deal with in this. But there's other situations as well. So first off, let me just say a few words about cancer staging in general along and get into that first. So we make a distinction between clinical staging and when we talk about cancer staging, which is most often based on imaging studies. And this is versus pathological staging, which is based on direct examination of tissue, often from a resection. It can also come from a biopsy or something like that. Pathological staging is generally considered to be most informative. So if you have the choice between using the clinical staging variable and a pathological staging variable, pathological staging is what you might go for, but it might not be available, so you have to use clinical staging instead. So that's one distinction that we'll make right off the bat. Staging reports staging reports generally break things up into 3 different sections. And this includes a T stage, which most often corresponds to tumor size or degree of invasion. And then the second part, section I'm calling it, is the N stage, which is the degree of invasion into the surrounding lymph nodes. And then you have M stage, whether or not there are distant metastases. Yes, that's generally a yes or no variable. These are evaluated separately, and they have separate variables in the tumor table. So you can look up a t value, clinical t value, a pathological t value, a clinical n value, and a clinical pathological n value, and then a clinical m value and a pathological m value as well. And so a typical stage report is like I have it here. I have an example of T2, and this is the first bullet that I'm looking at here. T2, N1, M0. That's a typical way these three sections are characterized in a staging report. And that corresponds, that particular pattern corresponds to different stage groups. And by stage group, I'm getting at stage one, stage two, stage three, stage four. So if we were to consider, let's just say, esophageal cancer, that particular pattern, T2N1M0, happens to correspond to stage 3A. There's a table in the AJCC staging manual that lists all combinations of the T, the N, and the M, and will tell you which combinations corresponds to stage one, which corresponds to stage two, and substages and things like that. Um, so in this case, if we're talking about esophageal adenocarcinoma, T2 means that the tumor invades the muscularis propria. I don't know what the muscularis propria is, but the pathologists do. And if the tumor extends into it, they say T2. N1 in the case of esophageal cancer means that the metastases were found in one or two regional lymph nodes. If there was more lymph nodes, it might be N2 or N3 or something like that. And in this case, M0 means no, there were no distant metastases like in the liver or something, some other place like that. And like I said, this particular pattern corresponds to group 3A. Um, all right. Other important variables here when you're putting together cancer cohorts. Data diagnosis I've already mentioned, but it's very common, and it's a good question to ask when you're talking to oncologists and researchers. Which time range are you interested in? Are you interested in really old diagnoses, or are you more interested in more current ones and things like that? Data diagnosis will help you with that. Sequence number is another important variable, and there's actually two sequence numbers in the specification: sequence number hospital and sequence number central. I'll say a little bit more about that distinction in a moment. But sequence number hospital is the sequence of primary cancers that occurred for that patient at that hospital. So if somebody shows up and they're diagnosed with, let's say, pancreatic cancer, and that's the only cancer that they were ever diagnosed with at that particular hospital, that pancreatic cancer would be given a sequence number of 00. Now, if this person is unfortunate enough then to have, let's just say, a lung cancer show up 6 months later, um, then that first pancreatic cancer would change from 00, and it would turn into 01 because it's the first of many cancers. And then the new cancer, the new primary lung cancer, would be given a sequence number of 02. And so the cancers are sequenced in this particular way. And so you might be interested, when you're putting together your cancer cohort, you might be interested in solitary tumors only, or the solitary tumors plus the first tumor only. It's important to know that the sequence number hospital only captures those that are at that particular hospital. The sequence number central is supposed to give you the sequence number of all cancers, regardless of where they're diagnosed. But it is very difficult for one particular hospital to know that information. They might not know it at all. And so that might not be accurate if it's coming from a specific hospital. Class of case is another important variable. And this reflects the fact that some people will show up to a hospital and they'll have their entire workup done at that hospital. They'll be diagnosed at that hospital, they'll be treated at that hospital. All their information is there. If you're going to look at the other tables in the CDM, they're going to be well populated with all the other procedures they have done. And those are the people that you might be most interested in compared to, for example, somebody who shows up just for a second opinion and they didn't have their treatment done there. They're only having, say, some diagnostic work done, and then they go back to their home hospital and everything. And so you might, it's very typical when you're dealing with registry information to include only the analytic cases. I put that in quotes. Analytic in this case means they either had their diagnosis done at that hospital or their treatment was done or planned at that hospital. Those are the analytic cases. Um, and like I said, you might consider kicking out anybody who's not an analytic case because the rest of their tumor table, or rest of their CDM information is likely to be incomplete and not have a good wealth of information there. So it's a typical thing that's done. Okay, let's talk a little bit about treatment of variables. Treatment's kind of like stage. There's a lot of treatment data in the tumor table. All the treatment variables names start with Rx, so they're pretty easy to it's pretty easy to determine whether the treatment value or not, variable or not. Um, the important thing, one of the important things to keep in mind when you're looking at the tumor table is that the registries only capture first course of treatment. And these are things that generally happen within say, the first 6 months. That's not a hard and fast cutoff, by the way. It's not like 6 months happen and they don't capture anything after that. Their goal is to capture the first course of treatment. Um, and so, if somebody was treated one way and then there was a second line of treatment, so for example, for neuroendocrine tumors, it's very common to get surgery and then they only get chemotherapy later if there's a reason to get chemotherapy. The registry data would capture the surgery, would not necessarily capture the chemotherapy. Um, there's variables for several kinds of cancer therapy, for chemotherapy, for radiation, for immunotherapy, everything. I'm generally suspicious of just about anything that's not surgery. And the reason for that is that I'm dealing with hospital data. The surgery is likely going to be done at the hospital where the abstract's done. You're likely to have good data in your surgery variables. And there's one example of the summary surgery at the primary site. That's the variable name right there. There's also another one for surgery at the lymph nodes. That has a different name, of course. Um, you generally have pretty good data for surgery from the registry tables. Chemotherapy, somebody might come to an academic medical center, they get diagnosed, and then they go home and get their chemotherapy at a local oncology clinic at their home. And so that data might not be complete at the hospital where you have the registry files here. Same thing with radiation or immunotherapy and things like that. So just keep in mind, just because there's a variable something for something doesn't mean that it's a good variable or it's well populated. It's also important to know surgery codes are site specific, and there's a resource for this at the end of my slides here. Um, Potential pitfalls. Well, I've been covering a lot of pitfalls so far, but here's some that I thought I'd deliberately name. One thing that I've mentioned a few times here, and I think we're all sort of painfully aware of, is the NACER specification changes over time. In particular, there was a big change in 2018. Just about anything that you want to look at, you want to look at how your variables are changing over time, especially just whether they're even populated or not. So those staging variables I mentioned, you'll see where they're null for a long period of time, and then suddenly like 2018 hits and now it's populated. It's just a good habit to get into for almost any of these variables to make sure that they're behaving in a way that's expected and don't just jump in and get the overall frequency without looking at how things might have changed over time. I mentioned the hospital versus central versions of variables in terms of the sequence number. You have the same thing for treatment variables as well, but in that case, the central versions are called summary versions. So back here, I talked about RX summary surgery at the primary site. This will capture ideally all surgeries done at any hospital at all. There's another version of this variable called RX HOSP, HOSP, surge primary site, that will tell you the surgeries that are done only at that particular hospital. So I always tend to use the summary variables just because I'm often most curious whether they had surgery or not, not that they had surgery at that particular hospital or not. Um, so summary variables are helpful, most informative, I think, when the information is there. Um, Another thing to keep in mind with the Naser variables is that there is that ascertainment lag that comes from the fact that it takes time for the abstractors to abstract the chart, and they're also waiting for that first course of treatment to be finished as well. So often they'll find a case, they'll let that case sit for a while until all treatment decisions have been made, and then they'll swoop in and abstract it. But the downside, you get a nice complete record from that, but the downside is that you're not going to get the people who were just diagnosed last month. There is that lag in ascertainment. And then something I mentioned just a moment ago, just because there's a variable doesn't mean it's well populated. And I mentioned chemotherapy in particular, but I think that's true in general. It's just a good idea to get in the habit of looking at the distributions of the values that the variable takes. And things. When I hesitate to even mention this, but we're fortunate actually in GPC to have a couple health systems here in the form of Alina and Intermountain. One of these days, we should take a look at completeness of some of these variables between the academic medical centers and the health systems. I'll bet the health systems have more complete data for some of those things than some of the rest of us. Okay, resources. So everybody, I think, has probably seen the tumor table specification at the GitHub site. You have the Naser data dictionary. There is also a really nice one. There's a link for the ICD-03 manual. Don't get those codes confused with ICD-10 codes. The SEER Registrar Staging Assistant. This is a really nice site for looking at those site-specific variables that I mentioned way at the beginning of the talk here. And I might just go ahead and well, I might do that later if we have a little bit of time. There's also a resource there for finding surgery codes, and then there's a special file at that at this. You might notice that this link has been here on each of the slides. So if you go to this link, there's a file there you can download to look at histology codes here. And I think I might stop my slideshow and show that staging assistant variable or resource real fast here. If you follow that particular link for the registrar staging assistant, it'll take you to this site. And then you can look at the particular era that you're interested in. So if you're looking at diagnoses that happened 2018 plus, that's what we call the EOD era. It'll then take you to a place where you can look at all the different schemas. And so like if I look at something like breast cancer, we can go down and it has all this. These are all the variables that are somewhat involved in staging. And then some of them have SSDI, that stands for site-specific data item. These are all the site-specific items for breast cancer. And so you have things like the estrogen receptor and progesterone receptor status, HER2 status, and the Ki67 that I mentioned before. So, and then it also gives you the NACER numbers for each of them as well. So this tells you, so if you're doing a study on, once again, pancreatic cancer or something like that, and you want to know what site-specific variables are available to you, look at this resource and it'll tell you what happens to be there. All right, I have an example to look at, but I am going to stop there and see if there are any questions at all before I go any further.
Brad, given all the caveats you have expressed about this data,
Yes.
what's it solid for? What kind of thing could we say this is sort of a first step is to go to the tumor table and look things up?
So if you're looking at a basic cancer cohort, like I want to find all pancreatic cancer cases that were diagnosed at my facility between this and this date, even with this particular histology, that is a fairly simple query to do, and that I think would probably cover a good 80% of what I do is that kind of query right there. The other 20% gets into all these caveats and things and more difficulty, which I don't want people to shy away from. I just want people to be aware that there's some nuance and some thought to go into it. Um, the nice thing about getting this data from the registry compared to, say, the diagnosis table is that you do have that class of case, and so you're able to determine, here's a set of pancreatic cancer patients who were diagnosed or treated at this particular hospital. They're likely to have good information if I go to the other CDM tables, um, and things like that. I think if you're not concerned about getting the most recent cases, there's that lag. If you're not concerned about most recent cases, the tumor table, the registry data is the most high quality source of cancer information that you could possibly use. And it is high quality data. The people who are abstracting these are required to be certified. And so it's extraordinarily high quality data. Does that answer your question?
Yeah, thanks. I was just
Yep.
thinking of things we could do as a network with that.
Yeah. Yep. Yep. Any other questions? Okay, let me just quick. I do have an example here that might, like I said, I was a little worried when I started this that I was gonna put you off the tumor table altogether. It's not that hard to query if you're just getting into basic things here. Now I know probably most people here are SQL programmers. I'm a SAS programmer, but I'm sure most people can kind of figure out what I'm doing here. And this is an actual query that I put together several months ago for one of our investigators here at Iowa, and they were interested in some breast cancer cases. With I think had to be ER positive and HER2 negative. That's the other nice thing about the registry data is you do have high quality information on these site specific variables. These site specific variables they're included because they're important. And so like getting ER status and PR status and HER2 status for breast cancer patients is really hard to extract from the medical record in any other way besides the registry data. Once again, very high quality data. So here, I'm doing a query. I'm looking for breast cancer. It's the first three characters of that code is C50. I'm looking for malignant breast cancer diagnosed between 2008 and 2022. Um, I worked with the investigator to determine which histology codes that we were going to look at, and I did that empirical approach where I I pulled out all the breast cancer patients, and then we looked at which histology codes were present there. The PI went through all the histologies and just checked off which ones they were interested in and which ones we were going to throw out. This is the list of ones that they were interested in. And like I said, this right here is probably 80% of what I would do with this table here. And then we get into the receptor status. Receptor status is a site-specific variable. It's captured differently before and after 2018. Here's where you can look at that registrar staging assistant to get some more information. So I'm looking at it differently between those two eras. And then I actually even and then created an indicator for that and made a nice little table to see how it looks across, one era compared to the other era of time that the site-specific variables cover. Um, and then did some other stuff with the surgery codes. Once again, I went to that surgery code resource, showed it to the investigator I was working with. She was interested in finding people who had a lumpectomy or a mastectomy, and she was comfortable with the values between 20 and 80. You can look up the actual what that means. Um, in that resource that I provided. So we looked at it, we kicked out all the ones that weren't those two, and then she had a nice cohort of ER positive, HER2 negative people who had been treated, surgically treated between the particular dates that she was interested in, and it's good high quality data. Um, and So possible next step for this query. So one of the things that you might want to do if you're doing a query like this is then you might have multiple records that satisfy your criteria. It's very common to go and find a set of criteria to find one record that serves as an index for that. Then you might want to link to some other CDM tables to assess procedures and lab values and clinical measurements. We have a paper published a few years ago that provides a nice example of that. You might want to de-identify and recruit for prospective data collection. We've talked about NetPro before and share thoughts on breast cancer before, and there's a link that provides some more information on that, so you can take a look and see how things are done as far as that goes there. Um, and then, of course, we have 8 questions left.